All right, welcome back to the grand finale of our macroscopic urinalysis module. Today, in this explainer, we're conquering the final 5 dipstick analytes on that chemical reagent strip, and ultimately unlocking the gateway to the microscopic exam. We've got a ton of high-yield, frankly fascinating clinical chemistry to get through, so let's jump right in. So here's our roadmap for today. We're going to recap briefly, then hit blood analysis, dive into our liver duo of bilirubin and urobilinogen, check for infections with nitrites and leukocytes, and wrap up with exactly when to reflex to the microscopic exam, plus a quick high-yield review at the end. Section 1. Recap and blood analysis. Let's get to it. Just to quickly set the stage, you already know the first half of the strip. pH gives us an instant reaction, protein is absolutely our #1 indicator for renal disease, glucose spills over right at that 160 to 180 milligram per deciliter threshold, and our ketone pad is highly specific for acidoacetic acid. Okay, solid foundation laid. Let's shift to our first new analyte, blood. And the absolute golden rule you have to remember here is that anything greater than 5 red blood cells per microliter is clinically significant. Now, what's really interesting is the stark visual contrast between the different types of blood you'll see in the urine. Take hematuria. That's intact red blood cells. Because those cells are intact, they make the urine look cloudy and red. And when they hit the reagent pad, they actually lyse right on contact, which creates this really distinct speckled pattern. On the flip side, we have hemoglobinuria. This means the red blood cells have already lysed, maybe from a hemolytic anemia or an incompatible transfusion. The result? Clear red urine, and a totally uniform, solid green-blue color on the strip. By the way, this lysis can totally happen in vitro, right in the sample cup, if the urine happens to be highly dilute and alkali. Let's add a third culprit to the mix, myoglobinuria. This happens when muscle tissue is actively being destroyed, a condition known as rhabdomyolysis. If you're trying to tell them apart, remember that hemoglobinuria might present with hemosiderin, those yellow-brown ferritin granules from reabsorbed hemoglobin, while myoglobinuria is associated with elevated CK and LDH enzymes in the blood. Also notice how myoglobinuria produces clear reddish-brown urine, but unlike hemoglobinuria, the patient's blood plasma remains perfectly clear. But here is the tricky part. Both hemoglobin and myoglobin have pseudoperoxide activity. That means they both cause a uniform, oxidized green-blue positive reaction on the dipstick. The strip literally can't tell them apart. So if the strip is completely blind to the difference, how do we figure it out? To truly differentiate them in the lab, we use the ammonium sulfate precipitation test. It's pretty straightforward. You add 2.8 grams of ammonium sulfate to 5 milliliters of urine, and the larger hemoglobin molecules just precipitate. They drop right out of the solution. Then we test the leftover liquid, the supernatant. If that liquid still tests positive for blood, boom, you know myoglobin is your culprit. Section 2. The liver duo. Let's pair up bilirubin and urobilinogen. To really grasp these tests, we have to follow the metabolic pathway. Think of it like a journey. When old red blood cells are destroyed, they break down into protoporphyrin, which becomes unconjugated bilirubin bound to albumin. This travels straight to the liver, where it gets conjugated with glucuronic acid, making it water-soluble. Then, the liver dumps this into the intestines, where normal gut bacteria go to work, reducing it into our second analyte, urobilinogen. Here's the crucial takeaway for the bilirubin pad. It only detects conjugated, water-soluble bilirubin. Why? Because the kidneys just can't filter the unconjugated, albumin-bound form. This pad is fantastic as an early indicator of liver disease, often turning positive way before a patient even looks visibly jaundiced. The chemistry here is a diazo reaction, turning a bluish-purple azo dye. But huge word of caution here. Bilirubin is super unstable. If a urine specimen just sits out in the light, the bilirubin photooxidizes into biliverdin. And biliverdin does not react with the strip, giving you a false negative. Oh, and excessive vitamin C, ascorbic acid, over 25 milligrams per deciliter, will also trigger a false negative. On the flip side, meds like pyridium or other pigments can cause a false positive by basically painting the pad. Since the strip can honestly be a bit tough to read and has a higher threshold, we confirm any positive with the IACTO-test tablet procedure. It's a brilliant little test. You put 10 drops of urine on a special absorbent mat, add the tablet, and follow up with 2 drops of water. Read it at 60 seconds. What happens is the mat traps the bilirubin right on the surface while washing all those interfering substances away into the fibers. It's incredibly sensitive. We're talking detecting levels as low as 0.05 to 0.10 milligrams per deciliter, compared to the strip's 0.4 to 0.8. If it turns blue-purple, you've got a confirmed positive. All right, moving to the second half of our duo, urobilinogen. Remember how this is formed in the intestines? Well, a small amount is naturally reabsorbed and filtered by the kidneys. So a normal urine strip will actually show a tiny bit of urobilinogen, usually less than 1 milligram per deciliter or about zero point 0.1 Ehrlich units. Elevated levels point straight to liver disease or hemolytic disorders. But here's a massive red flag. If urobilinogen is completely absent, it means something is physically blocking the bile duct, stopping bilirubin from ever reaching the intestines. Just note that the strips can't actually report a true negative, they just report normal. You absolutely have to know these 4 clinical jaundice patterns. For example, look at hemolytic disease. You have massive red blood cell destruction, which means negative bilirubin in the urine, but heavily elevated urobilinogen. Now check out the obstruction pattern at the bottom. The bile duct is blocked, so bilirubin backs up into the blood and spills into the urine in really high amounts. But urobilinogen? It drops to 0 because nothing is getting to the gut. It's such an elegant diagnostic puzzle. Section 3, the infection check. Moving into our rapid UTI screen. First up here is the nitrate pad. This is our rapid screen for UTIs, particularly looking for cystitis even before symptoms show up. It tests for reductase-positive gram-negative bacteria, most notably E. coli. Keep in mind, UTIs are about 8 times more common in females. These bacteria actually take normal dietary nitrate in the urine and reduce it to abnormal nitrate. The Grice reaction on the pad turns a pink azo dye. And here is the golden rule. Any shade of pink, literally no matter how faint, is considered a clinically significant positive and requires a follow-up culture. Usually it means there are around 100,000 organisms per milliliter. But please, listen to this massive clinical caveat. A negative nitrite does not mean the patient is UTI-free. False negatives happen all the time. Why? First, the bacteria need time to work. If the urine hasn't incubated in the bladder for at least 4 hours, which is why first morning collections are best, there just won't be enough nitrite to detect. Second, gram-positive bacteria simply don't have the reductase enzyme, so they won't trigger this pad at all. Also, if there's no dietary nitrate, no reaction. And yes, ascorbic acid strikes again, causing false negatives along with a high specific gravity. Partnered with nitrite is leukocyte esterase, or LE for short. Normal is negative, but this pad detects the esterase enzyme found in granulocytes, like neutrophils in monocytes. The real beauty of this test is that it detects intact white blood cells and lysed ones that the microscope might totally miss. But you have got to be patient. This strip uses a reaction that creates a purple color, and it takes a full 120 seconds to read. 2 whole minutes. That makes it the absolute slowest pad on the entire strip. There are some really wild clinical nuances with LE. For instance, the parasite Trichomonas actually contains its own esterase. This means a patient could have a positive LE pad without any actual white blood cells present. Also, watch out for harsh oxidizers, bleach, or formalin in the collection container because they will absolutely trigger a false positive. False negatives can happen with elevated protein, glucose, or high specific gravity causing cell cronation, plus oxalic or ascorbic acid, and certain antibiotics. Oh, and if you see a positive LE combined with a negative nitrate, immediately suspect a gram-positive infection, a fungal infection, or some sort of non-infectious inflammatory cause. Section 4. Reflex-to-microscopic. Let's talk about the decision matrix. All right, the macroscopic exam is officially done. So when do we actually need to look closer under the microscope? It all comes down to clinical efficiency. According to standard macroscopic to microscopic protocol, if a urine sample is visually yellow and clear and every single chemical pad is negative, we stop. No microscopic exam is needed. But if there is any abnormal color, abnormal clarity, or any positive chemical result, that triggers a reflex. We have to take that urine, spin it down in a centrifuge, pour off the supernatant, and examine that sediment under the scope. Section 5. High-yield exam wrap-up. Let's lock this in. Okay, let's wrap this capstone explainer with some high-yield memory tricks. First up, the mnemonic AVIDC. This reminds us that excessive ascorbic acid, vitamin C, is a notorious universal false negative agent. It suppresses the reactions for blood, bilirubin, nitrite, and glucose, as well as ketones. If your patient is chugging vitamin C, their dipstick results might literally be hiding some serious underlying pathologies. Quick memory test before we go. We've talked about a lot of reaction times across these 2 explainers. So, tell me, which chemical test pad requires the most patience before you can read the result? You got it. Leukocyte esterase is the absolute slowest on the entire reagent strip, requiring a full 120 seconds or 2 minutes. And that perfectly contrasts with the pH pad, which is the very first one you read because its reaction is instantaneous. And there you have it. That completely wraps up Module 1, our macroscopic urinalysis capstone. You now know nephron physiology, specimen handling, and exactly how to interpret every single physical characteristic and pad on the chemical dipstick. But as we just learned, abnormal chemistry means we're heading to the centrifuge. Which leaves us with one really provocative question. What fascinating unseen structures are waiting for us inside that microscopic sediment? We'll find out next time. Thanks for joining me on this explainer.